Hello, everybody. Hello, Dr. Nader.
Hello. How are you?
Should we start or wait for a few seconds?
Yes.
I guess we can start. Our first speaker is here.
Yes. Thank you so much.
Yeah.
Hi, how are you, everybody? My name is Iman Day. I'm the Yellow Team's leader. I hope everybody's doing well. And I know the season has started, coming up for the matching season this year. And I hope everybody's doing well in their progress. I just wanted to mention one thing because it was extremely helpful for me. In the app, there is a page where you can see the previous residents' ERAS application and personal statements, the residents who matched. So I think that would be quite helpful. It was very helpful to me. So I just wanted to highlight that one thing. So in today's session, 4 speakers. We will be covering the preoperative management of the geriatric patient by Dr. Isra Hamza, and we will be speaking about the NIH stroke score by Dr. Alsheikhaltayeb Azhari. We will be speaking about how to make a scattered plot with trend line in Excel by Dr. Minnu. And lastly, we'll be speaking about the geriatric appraisal by Dr. Hasan Tazy. And in the last 10 minutes, it would be an update about the projects that we're going. Dr. Nader was trying to show us where we can find the app. I think that would be quite helpful. Thank you, Dr. Nader, if you can show us. Yes, this is the ERAS document. You'll find the link to it in the main app application. You just the same way, you enter your address, you get a code in your email, and you log in. You'll find Dr. Nader was extremely helpful. So you'll just find the residents' personal
experiences. Yes.
Thank you.
It's been very helpful for me too, Dr. Iman. Hi, everyone.
Yeah, thank you very much, Dr. Nader. So our first speaker is going to be Dr. Isra Hamza. She's going to cover the preoperative management of geriatric patients. So if Dr. Isra, if you can share your screen and
yes, sure.
All right.
Assalamu alaikum, everyone. This is Dr. Isra Hamza. I'm going to start sharing my screen. Assalamu alaikum, everyone. Our topic today is very important, especially for those who are planning to take step 3 exam. The preoperative care in geriatric populations. Do you see my screen?
Yes, we do.
Great. Thank you, Dr. Iman. Do you know how I can, you see this, how I can remove this from my screen? Because I can't see the first line.
Oh,
anyway,
you mean like the bar on top?
Yeah, this top. I don't want this. I don't know how to hide this.
If you click on it and drag it, I think you can look it up.
What did you say?
If you draw it and click on it and drag it.
Click on it?
Yeah, when you click on it, it basically becomes smaller.
You can move it to the lower part, I think.
Or you can like move it, click on it and move it to the side maybe. Because it doesn't show right here when you're sharing your screen, we can't see it. You are the one who can only see it. Dr. Isra, you're muted.
Oh, sorry. I'm sorry. Yes.
Okay.
So again, my objectives today is to be able to cover the following. We are going to describe how age-related physiological changes influence perioperative care, and also risk factors for cardiovascular, pulmonary, renal, and neurologic complications, elements of pre-op management of selected medical problems, and also how to avoid the iatrogenic complications of anesthesia and surgery. Do you hear me, everyone?
Yes.
Yes, we can hear you.
Yes, okay. And also we are going to cover the overview of operative therapy for older people. And when we take a surgical decision to perform surgery on a geriatric patient, and this is extremely important decision, pre-op assessment and management, in addition to perioperative and post-operative management of selected medical problems such as cardiovascular problems. Regarding surgery in geriatric populations, more than 55% of all surgeries are done in patient age 65 and more. Advances in care have lower surgical risk and shifted the risk-benefit ratio to favor surgery in increasingly older patients with more complex conditions. So it's only reserved for difficult conditions. Not any patient should have surgery. While surgery per se is a safer, older adult experiences a disproportionate majority of post-op morbidity and mortality. As we know, with aging, there is increased risk of cataract, arthritis, and cardiovascular diseases such as hypertension and diabetes. So what are the physiological changes that is really influence perioperative care? As a result of normal aging, there are multiple organ systems who have limited physiological reserve with time. Best example of that, cardiovascular, cardiac and vascular stiffening will complicate fluid management, and also decreased thermoregulation with aging will lead to increased risk of preoperative hypothermia. Stiffening of thoracic cage with advanced age will limit the pulmonary reserve as well as diminish auxiliary function. Of the outer body composition, such as decrease in kidney function and also hepatic blood flow, will lead to decreased hepatic enzymatic activities, and eventually this will definitely affect the pharmacodynamics of medications, especially anesthetic medications. Perioperative care for each individual, for each patient should be individualized. Not all organ system age in the same rate, even within one patient. Most patient, elderly patient, one or more chronic conditions that may affect perioperative care, either directly or through drugs themselves. And I mean by that, if the patient has, for example, hypertension will affect definitely the patient during surgery, increased risk of bleeding. It could be rise during surgery, and medication used for controlling this hypertension itself, like beta blocker or calcium channel blocker, would affect anesthetic medications. So those older patient requires a thorough and individualized perioperative care and often benefit from multidisciplinary approach. Like, for example, could involve a pulmonologist and also nephrologist, physiotherapist to be part of the patient plan. So when we take a decision of surgery, it's a really serious decision, and the geriatrician should be involved in making this decision with the patient and his family, and also with the surgeon. We should be very clear with the patient about the expected outcome and possible complications of surgery itself, or the outcomes of the surgery, like limitation of daily living activities, or it could be some patient ended up in nursing home facilities rather than home, and also possible of frailty and malnutrition. So like too many things to think about. If the patient decided that the surgery would be best option for him, then we proceed and involve the surgical consultation. So patient goals of care should be elicited, and also surgical consultation should be pursued only if consistent with patient-oriented goals. I'm going to start with cardiovascular risk assessment. This is a big topic. So the risk of post-operative care cardiac event is directly related with age. There are two modalities of how to predict the cardiac risk in patient undergoing surgery. There is the ASA classification, which stands for American Society of Anesthesiologists. So this classification have been used for years now by anesthesiologists. It basically predicts the outcome in patient undergoing surgery by assessing their physical status. They are grading patients into 5 groups, ranging from group class 1 up to 5, basically from patient with normal health. This is class 1, and we have AS2, which is for patient with mild systemic disease. And then we have patient with severe systemic disease, and eventually patient with life-threatening disease. And the last class, which is extremely critical, that those patients are not expected to live to survive more than 24 hours with surgical intervention or not. The second modality is we have the American College of Cardiology guidelines and also the American Heart Association guidelines, and I'm going to discuss this in a few seconds. So we will start first question. This is the recent guideline. Is this surgery necessary for this patient? If yes, that means this is life-saving procedure and we should proceed to surgery. If no, that means the surgery is not urgent. So what question we should think about? If there is any of the following major risk factors present on this patient, is this patient, for example, having unstable angina, or having a myocardial infarction in less than 6 months, or this patient is experiencing decompensated heart failure, or moderate to severe valvular disease, or dyspnea. If one of these major risk factors present, then we should cancel or postpone this surgery. We should control this. We should make an adjustment or operative care for this patient. And I mean by that, workup like assessing valvular function by doing echo or addressing dyspnea. If this patient having congestive heart failure, we should treat heart failure before proceed to surgery. Okay, let's move to the next question. If the patient have major risk factors, as I mentioned above, sorry, no, he has been any major factor. Is the surgery is low risk surgery, and I mean by that, like eye surgery, like cataract or endoscopic procedure, breast or plastic surgery, or superficial skin surgery? If yes, then we could proceed to surgery immediately. Proceed to surgery. So, if no, that means this patient is having, for example, AAA surgery repair. If the patient is able to do heavy housework, like performing yard work, climb or a flight or steps, walk up a hill, run in short distances, as you notice, all this predict the physical activities of the patient, if this patient is fit or not. So if yes, we proceed to surgery. We proceed to surgery. If we don't know if this patient could do any of this, or this patient has limited mobility, cannot go upstairs or whatever I mentioned, then next question. Is the patient medically appropriate and willing to undergo testing for cardiac ischemia and revascularization before surgery? First question. Then, will further information on cardiac risk impact decision to proceed with surgery or operative care? If yes, the patient agrees, and we will gonna benefit from this investigation we are planning to do, then we should calculate cardiac risk and consider perform cardiac stress testing, either as cardiac stress test by treatment or pharmacology. And if abnormal, then we're going to proceed to revascularization, which either covered by blood grafting or angiography, PCI. If the patient is unwilling to proceed or to do any of these investigations, then again, we should discuss potential risk with the patient and benefit of the surgery and with the surgeon also, and decide whether or not to proceed with surgery. This is basically the guidelines. Okay. The next step, we decided this patient need preoperative assessment for cardiovascular disease, like let's see, ischemic heart disease. We should do complete physical history and physical examination. And it's very important to know not every patient with cardiovascular disease should undergo either ECG or echo. There are specific circumstances. First, we need baseline ECG, established ECG for any patient undergoing, we don't need ECG for patient undergoing non-low risk surgery, okay? Sorry, I'm very sorry. Okay, I'm gonna start again. Perioperative ECG useful as a baseline in patient with heart disease undergoing non-low risk surgery because post-operatively we could compare the pre-op ECG and we could notice if there is any changes in pre and post-op. Also, if the patient experiencing dyspnea of uncertain cause, we need to do to echo and measuring of the left ventricular function to exclude this patient is not experiencing heart failure, because if he's having heart failure, we need to medic heart failure before surgery. The third situation that if the patient with moderate or worse valvular stenosis or regurgitation, we should check the operative echo, especially if he has no echo in the last year. Major indication for revascularization in preoperative period. So after finishing with ECG and echo, which patient should undergo revascularization? First group of patients when there is significant unprotected left main vessels disease, or if there is 3 vessels disease, or if there is 2 vessels disease with proximal left anterior descending disease, or patient survivor of sudden cardiac death with presumed ischemic ventricular tachycardia. For those groups of patients, we need to do revascularization. And we need to use some medications could give before and after surgery, and this could reduce cardiac and vascular complications of surgery. Okay. Regarding anticoagulation, there are too many geriatric patients using anticoagulation either due to atrial fibrillation or any kind of arrhythmia. So what if these patients are undergoing surgery? We should weigh protective benefit versus bleeding risk in patient already on anticoagulation. According to hypercoagulability status of the patient, if this patient is having high risk of thrombosis, like patient with mechanical valve, or if this patient undergoing major surgery like AAA repair, and there is a risk of bleeding. So don't withhold for cutaneous surgery. This is low risk surgery like skin surgery, dental extraction, minor oral procedure, and cataract surgery. We don't need to stop anticoagulation. For those procedures, other than that, major surgeries, sedation of warfarin with or without low molecular weight heparin pyridine therapy may indicated according to the patient's risk of thromboembolism, as I mentioned above. Am I going too fast?
No, I think you're going good.
Okay, great.
Nobody's commenting, so
okay, great. So there is a specific group of patients who underwent coronary stenting, either bare metal stenting or direct eluting drugs. If this patient has an indication for elective surgery, what we are going to do? Cohort study identifies substantial increased risk of major adverse cardiac event when surgery is performed sooner after coronary stent place. So we need to wait. Regarding optimum timing for elective surgery, patient having bare metal stent, we should not do it before 30 days after insertion of the stent. Only 30 days. However, patient with drug-eluting stent, we should wait up to 1 year after insertion of the stent. This is about cardiovascular system. Next, we have the respiratory system. Major risk factors for pulmonary complications is either related to the patient himself or related to the procedure. Patient related factors, either age of the patient, patient with chronic obstructive pulmonary disease, patient with ASA class 2 or greater, or patient having heart failure, activity daily living deficit patient, and also patient with low albumin. This is high risk group of patients. Regarding surgical procedure, if this surgery is emergency surgery, and the second is how long this surgery would take. If it's more than 3 hours prolonged surgery, this is also a risk of pulmonary complications. And also we have AAA repair, abdominal aortic aneurysm repair surgery, neurosurgery, thoracic, abdominal, head and neck, and also vascular surgery. General anesthesia per se considered is a risk for pulmonary complications. By pulmonary complications, I mean pneumonia, atelectasis, and need for prolonged intubation. And they found that if the patient develop any pulmonary complications, there will be increased risk of prolonged hospitalization, and eventually this will increase mortality. So we should manage patient very well and identify who patient at risk to prevent these complications from happening. According to the 2007 American College of Physicians guideline for risk assessment and perioperative management of pulmonary complications, first we should appraise risk factors, and that means assess patient groups of patient at risk. Then routine chest X-ray is not recommended for everyone. Is not recommended except for non-cardiac or pulmonary disease in patients undergoing thoracic, upper abdominal, or triple A surgery. So this group of patients need chest X-ray preoperatively. Spirometry is also recommended for patients suspected but not yet diagnosed with chronic obstructive pulmonary disease. So if we have this suspicion, this patient having chronic cough and he may have some sort of COPD, we should do spirometry preoperatively. Because if this patient having experiencing exacerbation, we need to control this exacerbation before proceeding to surgery. Spirometry is also indicated for patients who are undergoing lung reduction surgery. After surgery, postoperatively, lung expansion therapy is recommended, and I mean by that chest physiotherapy. Next system, we have kidney function, perioperative assessment. It's the better way to estimate the kidney function is through glomerular filtration rate. Accurate estimation of GFR is extremely important. Renal and glomerular blood flow decrease with aging, and also muscle mass will decline. So serum creatinine may appear normal even though when the kidney function is not. So we need to measure the GFR either using Koch-Gault equations or by using the MDRD methods. Both of them could provided by lab, automatically reported. And also we need to, many drugs that could use preoperatively may require dosage adjustment if renal function is impaired. And also fluid administration is crucial on patient that is having any kind of renal impairment. Okay, so next step is risk of delirium. So what are group of patients that may have anticipated to have this delirium postoperatively? First, we have patient age 70 or more, and also patient with cognitive impairment, limited physical activities, alcohol abuse history of patient, and also if the patient has abnormal serum electrolyte like sodium, potassium, or glucose, and also regarding surgery, intrathoracic surgery, or abdominal aneurysm surgery. The most important intraoperative risk factor for delirium is blood loss. Okay, so all of these factors are preoperatively. If the patient decline in hematocrit postoperatively by 30%, that means this patient has high risk to develop delirium, even if his preoperative assessment, if he has no risk preoperatively. Any question at this point? Okay. Function status and priority. Patient who require help with instrumental activity daily of living and also ADLS are at risk of poor surgical outcomes. Priority has been associated with 3 to 13-fold increase in being discharged to nursing facility rather than home, and also higher rates of delirium, cognitive impairment, functional decline, and death. And it's very important to discuss this with the patient and the family before to the surgery. And because they should understand the risk associated with priority or poor functional status when considering surgery, and also consider whether alternative options may be appropriate depending on the patient's goals of care, as I mentioned earlier. So how to avoid iatrogenic complications for the patient before and after surgery or during hospitalization? encourage time out of bed and avoid restraints. And also by doing, this will gonna be accomplished by early consultation of physical and occupational therapists. When it's appropriate or reasonable, we should just introduce them to help the patient to recover quickly, and also remove indwelling catheters as soon as possible. This will gonna help two goals. It will minimize risk of infection, and also it will help the patient to avoid risk of developing thrombosis and help in mobility of joints. So there's great benefit of removing catheter early. And also stop intravenous fluid whenever we could, and lift restrictions on diet as soon as possible so the patients could return to his pre-admission state of health. Also reviews medication regularly to make sure we are not, if the patient, for example, doesn't need opioids anymore, it's better to just review medication every time. So if this patient after surgery develop hypertension, and he hasn't have high blood pressure before, we should search for non-cardiovascular risk factors such as pain or urinary retention. Pain per se could increase blood pressure and also urine retention. And it's crucial to assess volume status of the patient by reviewing fluid administration and note whether this antihypertensive were omitted if the patient is hypertensive. And also, we could consider parenteral antihypertensive medications for treating uncontrolled essential hypertension when the patient having NBO, nearby mouth. We could use topical nitroglycerin like vasodilator, which may be helpful post-operatively if the patient is unable to take oral medications. Any question, everyone? I hear someone talking. No? Okay. So this is very, very important part of my session is supraventricular tachycardia, perioperative care. Associated with history of prior supraventricular dysrhythmia, asthma patient with heart failure, or premature atrial complexes on pre-op ECG. Okay, so more common in patients who have vascular abdominal or thoracic surgery. And I remember this one of the questions that on the step 3 exam about the complications of patient underwent cardiac surgery is atrial arrhythmia or atrial fibrillation in first few weeks, and usually it resolved after a while. So attempt to restore sinus rhythm is important, or at least control the ventricular rate, either by infusion adenosine or beta blocker or calcium channel blocker. Both of them are rate control. If the patient develop heart failure post-operatively, what we could do? Patient may develop heart failure as a result of excessive fluid administration, or if the patient develop new cardiac ischemia and also arrhythmia. It could be difficult, challenging to ensure optimum ventricular filling pressures by basing the assessment of volume status and physical exam and standard lab parameter. There is option of pulmonary artery catheter have been recommended for high-risk patients. However, the study does not show mortality benefit, and most authorities advised against this approach. What if this patient develop renal impairment postoperatively? Early sign of postoperative kidney damage is oliguria and isothinuria, which means basically either diluted urine or high osmolarity urine, and also definitely increase in serum creatinine. There are 3 mechanisms that could occur. This damage could be due to either impaired renal blood flow, or it could be due to acute tuberous necrosis or obstructive nephropathy, and this commonly in men with benign prostatic hyperplasia due to obstructive nephropathy. Best management we can do to those group of patients is hold any potential nephrogenic medications such as antibiotics or, for example, or NSAID, nonsteroidal inflammatory drugs, and meticulously maintain an EU volumic status for the patient. And if this patient experiencing obstructive nephropathy, insertion a urinary catheter will definitely reduce the risk of hydronephrosis and help improve renal function. Gastrointestinal tract complications postoperatively could be either due to constipation or diarrhea. Constipation is common in elderly patients. Order laxative and stool softener when ordering opioid analgesics is recommended, and also consider suggesting brune juice, applesauce brands, which will help facilitate softening of the stool. If the patient have experienced diarrhea after surgery, we should think about Clostridia difficile. So we should do stool analysis, but before that, we should do check manually for fecal impaction, and also consider looking for Clostridia difficile toxin in stool. And of course, if this patient having Clostridia, we should treat appropriately, accordingly, focus carefully on volume resuscitation and treating the underlying cause. Perioperative care in type 2 diabetic patient, taking oral hypoglycemic medications. Oral drugs usually held the day of the surgery, especially metformin. It's associated with increased risk of metabolic acidosis, especially during surgery due to stress. One option for managing glucose during prolonged fasting is administer intravenous glucose. At the same time, we should monitor frequently the blood sugar to make sure that we are not giving high amount of glucose. And also, we should consider giving patients subcutaneous insulin accordingly to his blood sugar to avoid hyperglycemia. And when the patient starts taking orally, he could resume his pre-admission dose. Many type 2 diabetic patients will be fasting for less than a day, can be safely managed by withholding long-acting diabetic agent and treating hyperglycemia with short-acting insulin. Okay, so if the patient having diabetes and he has at risk of both hyper and hypoglycemia in perioperative period, if the patient taking insulin at the day of the surgery, we should withhold the outpatient dose of insulin and give a sliding scale. With fasting and decreased oral intake, the dose pre-admission dose of insulin would not be appropriate for the patient. Okay, so again, monitoring the patient's blood sugar and by doing sliding scale and give him insulin as appropriate. And when the patient can consume a usual diet, then we should resume full doses of diabetic drugs. I mean by that insulin. How about patient taking corticosteroid? Surgery per se is stress, so we need to increase doses for those group of patients. Perioperative administration of stress doses of steroids is appropriate for a patient on prednisone more than 20 milligrams per day for more than 1 week, and also patient on prednisone because they are having adrenal insufficiency. If we thought about HPA axis, hypothalamus pituitary axis dysfunction, we need to check serum cortisol and doing ACT stimulation test to check for adrenal insufficiency. How to reduce risk of delirium postoperatively? Okay, when preoperative risk factors are present, clinicians should be especially vigilant about reducing sleep interruption postoperatively, and also make sure the patient is well hydrated, reduce dehydration, encouraging mobility, and also avoiding restraints, enhancing sensory input, minimizing medications, especially lorazepam, and also controlling pain, constipation, and correct electrolyte abnormalities, which could precipitate delirium. Cognitive dysfunction, consider a syndrome distinct from delirium. It basically is characterized by abnormalities in learning and memory that could happen to patients postoperatively, most common after cardiac surgery. Persists for many months in 10 to 30% of patients. No demonstrated link to hypotension, hypoxemia, or type of anesthesia, and basically the treatment is only supportive. Regarding pain management, old and cognitive impaired patients are at high risk of undertreatment of pain. Most post-surgical pain requires opioid analgesia. For cognitive intact patients, we could consider PCA pump, which is patient-controlled analgesic pump, to improve pain relief and lower use of opioid. Opioid analgesia may precipitate constipation, so it's recommended to give the patient a laxative and stool softener when we are giving him opioid. As with older patients, opioid should be used at the lowest effective dose for shorter duration of time in order to reduce the risk of associated complications with long-term use. Patient, when discharged at home on opioid analgesics, we should give them a prescription of naloxone with instruction for its use. Less severe pain, patient may tolerate acetaminophen. We could give them like less than 4 grams per day of acetaminophen with narcotic analgesics as needed, if able to request pain them. If patient is unable to communicate effectively, patient with cognitive impairment, standing orders for narcotic analgesics with guidelines as to when to withhold and with frequent assessment of medication side effect. Also, we should avoid non-steroid anti-inflammatory medications because of potential risk of gastrointestinal bleeding, delirium, fluid retention, and nephrotoxicity, and also cardiovascular risk. We could use adjustment like ice packing, heating baths, massage, and relaxation techniques to patients. So I'm almost done. The recommendation of GRS is don't perform stress cardiac imaging or advanced non-invasive imaging as perioperative assessment in patients scheduled to undergoing low-risk non-cardiac surgery. Patients who have no cardiac history and good functional status don't require perioperative stress testing before non-cardiac thoracic surgery. Don't perform perioperative medical tests for eye surgery unless there are specific medical indications. Avoid echo for pre-op and pre-op assessment of patients with no history of symptoms or symptoms of heart disease. And also, we shouldn't order coronary artery calcium scoring for preoperative evaluation for any surgery, irrespective of patient risk. Do not initiate routine evaluation of carotid artery disease before cardiac surgery in absence of symptoms or other high-risk criteria. Before cardiac surgery, there is no need for pulmonary function tests in the absence of respiratory symptoms. And also, finally, don't obtain perioperative test X-ray in the absence of clinical suspicion of intrathoracic pathology. Any question, anyone? Do you have any question? Okay, then I'm going to proceed to summary. Summary of my session today: perioperative care of geriatric population. Surgery is an important therapeutic option for many older people. Perioperative assessment should be individualized, comprehensive, and often multidisciplinary. Attentive perioperative management minimize complications in older patients, especially those with chronic medical problems and functional impairment. If you have no question, we have 3 cases. Anyone has any comment? Dr. Nader, do you have any comment before I proceed?
Not right now, thank you.
Great. So we have 3 cases. First case, 78-year-old man, come to the office for perioperative assessment. He is scheduled for total hip arthroplasty for sharp, severe non-radiating pain in his left hip. He has stopped walking because of the pain and depends on his wife for meal preparation and most household chores. He has history of hypertension, diabetes, chronic kidney disease, and osteoarthritis. Medications include insulin, atorvastatin, acetaminophen as needed. So he's diabetic, couldn't have chronic kidney disease, and also he's on insulin. On examination, active range of motion on the left hip is limited by pain. In his ECG, there is normal sinus rhythm and Q waves in lead 2, 3, and AVF. So he had all the ischemia, right? Laboratory finding PuN38, creatinine 2.1, and hemoglobin A1C 7.4%. Which of the following is the most important, is the most appropriate next step? Coronary angiography, exercise treadmill testing, pharmacologic stress test with imaging, or no further test necessary. I will give you 15 seconds.
I will monitor the chat for you.
Yes, please. Thank you, Iman. Do you have answers?
Yeah, people are saying D, no further testing.
Okay. Mm-hmm.
Yeah, everybody's saying D.
Okay, so this patient has all the ischemia, right? And he has renal impairment. And he undergoing hip replacement. So the right answer is this patient we should do pharmacologic stress testing with imaging to assess for ischemic cardiac disease in this patient. All right. So next case, 72 years old woman with pancreatic cancer undergoes resection with Whipple procedure. Surgery is uneventful, but her mental status changes abruptly the first day after the procedure. She's awake, combative, and agitated. She believes that she's at home and that her daughter is holding her against her will. The nurse reports that she has had 2 such episodes in the postoperative period. On examination, blood pressure 112/80, heart rate is 106, she's tachycardic, she's disoriented, abdominal incision is not erythematous or tender, so no signs of infection. Reminder of physical examination is unremarkable. Again, this patient, 72, having pancreatic cancer, and now she is experiencing delirium, and she is tachycardic. Which of the following is the most appropriate next step? Obtain ECG and major cardiac biomarkers, request neurologic consultation, administer lorazepam, or administer vancomycin and cefepime. I will give you 15 seconds. Iman, do we have answer?
Not yet.
Okay.
Okay, A, we have A.
Yeah, yeah, great. Yes, okay. Yes, I agree with you. We should do ECG for this patient. Yeah, ischemic heart disease in older patient could present atypical. So this delirium could be due to ischemia or due to electrolyte disturbance. So we should order an ECG and major cardiac biomarkers for this patient. Last case. We have 67 years old man come to the office for perioperative assessment before elective resection of parotid adenoma. It's scheduled to take place in 2 weeks. Other than facial swelling, he feels well and has no major symptoms. He has history of diabetes, hypertension, coronary atrial fibrillation. So he has atrial fibrillation. His medications include amlodipine, apixaban, and metformin. He is on anticoagulation. Okay. Which of the following is the best approach to manage the anticoagulation perioperatively? Stop apixaban 2 weeks before surgery. Stop apixaban 2 weeks before surgery and bridge with low molecular weight heparin. Stop apixaban 2 weeks before surgery, bridge with unfractionated heparin, or continue apixaban. Again, 15 seconds.
We have B.
Okay.
A and B. So people between A and B.
So the surgery, Okay. Okay, so the surgery is major, which is parotid adenoma, right? And he's on apixaban, and he has atrial fibrillation, but he is at not high risk of thrombosis, right? Sorry. Okay, so we should stop apixaban 2 weeks before surgery. B is not right because Bridging is only for patient with high coagulability status, high risk of thrombosis, and it's mainly for warfarin. So we could just stop apixaban 2 days before surgery and proceed to surgery to avoid risk of bleeding. Any question, everyone? Thank you very much for being so patient. It was extremely long topic. Thank you.
Thank you, Dr. Isra. This was a very, very informative, very, very good topic. And thank you for your presentation.
Welcome. Okay, so we are going to stop sharing, right? Okay, but I'm still here. If you have any question, I'll be glad to help.
Yes, if you have any questions, feel free to send them into the group, the chat. If you watch it later and you have questions, feel free to send them into WhatsApp group as well. Again, thank you.
Yes, you're welcome. This topic is very important for people who are taking step 3 exam. Yeah.
Yeah.
I hope it's been helpful for everyone.
I can tell you it's very helpful for me, and I'm taking my
Great.
right now. So
Great.
thank you very much.
Thank you. Thank you. I appreciate it, everyone. Thank you for being so patient.
So our next speaker is going to be, our next presenter, is going to be Dr. Alsheikhaltayeb Azhari. He's going to be speaking on the NIH stroke score. So Dr. Azhari, if you're here, please.
Yeah. Hello, everyone. I hope you are doing well. I will share my presentation now. Do you hear me well?
Yes, but it's a little bit far. I'm not sure if it's just me. So.
Okay, how about that? How about now?
Yeah, I can hear you well.
Okay, thank you.
And I can see the screen as well. So.
Okay, hello, everyone. I am Alsheikhaltayeb Azhari. I am going to present National Institute of Health Stroke Scale. Okay, the NIH stroke scale is a systemic quantitative assessment tool to measure stroke-related neurological deficit. In clinical practice, it can be used to evaluate and document neurological status in acute stroke patients, determine appropriate treatment, and assist in standardizing communication between healthcare practitioners. The NIH stroke scale has been shown to be a predictor for both short and long-term outcomes of a stroke. Okay, the NIH stroke scale measures several aspects of brain function, including consciousness, vision, sensation, movement, speech, and language. A certain number of points are given for each of these physical and cognitive functions during a focused neurological examination. A maximum score of 42 represents the most severe and devastating stroke. The level of stroke severity as measured by the NIH score system are scores 0 indicate no stroke, score from 1 to 4 indicate minor stroke, score from 5 to 15 indicate moderate stroke, 15 to 20 indicate moderate to severe stroke, 21 to 42 indicate severe stroke. Okay, here are our rules regarding the NIH stroke scale. Okay, we administer the scale items in the exact order. We score what we see, not what we think. Okay, the score is the first response, not the best response. Don't coach the patient. With okay, don't coach the patient. Sorry. Okay, the first item is the level of consciousness, and it has 3 parts: 1A level of conscious, 1B, and 1C. Okay, the first item, 1A, is the examiner overall impression of the patient alertness. Normally, you will get enough information when taking the patient history. To make this assessment, ask the patient 2 or 3 questions regarding the circumstances of the admission. For example, you can ask patient, are you having any pain today, or are you comfortable now, and record his response. Okay, we give a score 0 if the patient is keenly responsive or alert. We give 1 score if the patient is not alert but arousable by minor stimulation. We give 2 points if the patient not alert and requires repeated stimulation to attend, or requires a strong or painful stimulation to make movement. We give 3 points. We give 3 points when patient responds only with reflexive motor or autonomic effect. or totally unresponsive. Here we can say the patient is in a coma. Okay, the level of consciousness when be the patient is asked the month and his age. The answer must be correct. There's no partial credit for being close. For example, if you ask the patient what his or her age, and he replied with I was born in 1992, his answer is wrong. Okay. The patient should answer the exact question. Okay. If physical and stubborn patient who do not comprehend the question will score 2. Patient unstable, patient unable to speak because of endotracheal intubation or tracheal trauma, severe dysarthria from any cause, language barrier, or any other problem not secondary to aphasia are given 1 point. It is important that only the initial answer be graded and that the examiner not helping the patient with verbal or non-verbal cues. Okay. We give scores 0 if both if 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 both question answered correctly. We will give 1 point for answer if the patient answers one question. We give 2 points if the patient answer neither question correctly. Okay, well, level of consciousness when see here commands. The patient is asked to open and close the eyes and then to make a fist. We start with non-paretic hand. Yes, we can substitute another one-step command if the hand cannot be used. Credit is given if an unequivocal attempt is made, but not completed due to weakness. If the patient does not respond to command, the task should be demonstrated to him or her, and the result is scored. Patients with trauma, amputation, or other physical impediment should be given suitable one-step command. Only the first command, only the first step attempt is scored. Okay, we give score 0 for performs both tasks correctly, one for performs, one if patient performs one task correctly, 2 if patient performs neither task correctly. Okay, here item 2, best gaze. Only horizontal eye movement will be tested. Voluntary or reflexive eye movement will be scored, such as oculocephalic reflex, but caloric testing is not done. If the patient has a conjugated deviation of the eyes that can be overcome by voluntary or reflexive activity, the score will be 1. If a patient has an isolated peripheral nerve palsy, for example, oculomotor nerve palsy or abducent palsy, score will be 1 also. Gaze is testable in all aphakic patients. Patient with ocular trauma, bandage, pre-existing blindness, or other disorder of visual acuity or fields should be tested with the reflexive movement, like oculocephalic reflex, and the choice made by the investigator. Establishing eye contact and then moving above the patient from side to side will occasionally clarify the presence of a partial gaze palsy. Here we give this 0 if normal. We will give 1 point if there is partial gaze palsy. We will give 2 points if there is fourth deviation. Okay, item number 3 is visual. Okay, the visual field are tested by confrontation using finger counting or visual read as appropriate. Patient may be encouraged, but if they look at the side of the moving finger appropriately, this can be scored as normal. If there is unilateral blindness or inoculation, the visual fields in the remaining eye are scored. Score one only if a clear-cut asymmetry, including quadrantopia, is found. If patient is blind from any cause, scored 3. Double simultaneous stimulation is performed at this point if the patient is blind. Okay? If there is extension, the patient receive a 1 point, and the results are used to respond to item 11. We will discuss it later. Okay, here we will give 0 if no visual loss. We give 1 point for partial hemianopia or quadrantopia, unilateral or bilateral. We give 2 points for complete hemianopia, unilateral hemianopia, and we will give 3 points for bilateral hemianopia or cortical blindness. Item number 4, facial pulsing. Okay, here we ask or use pantomime to encourage the patient to show teeth, raise eyebrows, and close eyes. Score symmetry of grimace in response to negative stimuli in poorly responsive or non-comprehending patient. If facial trauma, bandage, or orotracheal tube tape or other physical barrier obscure the face, these should be removed to extent possible. We give a 0. We give 0 if the face is normal symmetrical movement. 1 for minor paralysis like flattened nasolabial fold and asymmetry on smiling. 2 for partial paralysis, and 3 for complete paralysis of one or both sides. Okay, item 5, motor arm. Here the limb is placed in the appropriate position. Extend the arm on 90 degrees with palm down, or if the patient is in sitting position, or 45 degrees if the patient is lying down. Okay, we will give a score 1 if no drift. Okay, we will give 1 point if there is drift. The limb holds 90 degrees, but drift down before full. Okay, sorry about that. Okay, give me a second. Sorry. Sorry. Okay, item number 5, motor arm. Okay, I will start it from the beginning. The limb is placed in appropriate position. Extend the arm 90 degrees if the patient in this sitting position, or 45 degrees if the patient is in supine position. Here we give 0 score if no drift, and we will give 1 point. We will give 0 score if no drift for full 10 seconds, and we'll give 1 point if the arm is drift. Okay, but drift. Okay, I'm sorry, I'm a little confused. Sorry. Okay, we give 2 point if there is a drift. Limb cannot get to or maintain 90 or 45 degrees. Drift down to bed, but has some effort against gravity. Score 3 if there is no effort against gravity. Score 4 if no movement, or the pair. Okay, we will write unstable in case of amputation or joint fusion at the shoulder. Item 6, motor leg. Okay, here we place the limb in the appropriate position. Hold the leg at 30 degrees. Drift is score if leg falls before 5 seconds. The aphasic patient is encouraged using urgency in the voice and pantomime, but not nauseous stimulation. Each limb is tested in turn, beginning with a non-bariatric leg. Only in the case of amputation or joint fusion at the hip, the examiner should record the score as unstable and clearly write the explanation for this choice. Okay, we give a 0 score if no drift. The leg holds the 30-degree position for full 5 seconds. 1 point if the leg falls by the end of 5-second period but does not hit the bed. 2 for some effort against gravity. A leg falls to bed by 5 seconds but has some effort against gravity. 3 point if the leg falls to bed immediately and no effort against gravity. 4 if no movement at all. Unstable if the amputation or joint fusion. Okay. Item I can see it. Okay. Item number 7, I think, limb ataxia. This item is aimed at finding evidence of a unilateral cerebellar lesion. Test with eye open. In case of visual defect, sure testing is done in intact visual field. The finger, nose, finger, and heel shin tests are performed on both sides. An ataxia is scored only if present out of proportional weakness. Ataxia is absent in patient who cannot understand or is paralyzed. Only in the case of amputation or joint fusion, the examiner should record the score as unstable and clearly write the explanation for this choice. In case of blindness, test by having the patient touch nose from extend arm position. Here we give 0 for absent, no ataxia. When for if there is ataxia present in one limb, 2 ataxia in 2 limbs, unstable if unstable for amputation or joint fusion. Item number 8.
Sensory. I think you can see it, right?
Okay, no, I can't see it. Okay, yes. Sorry. Okay. Sensation or grimace to pinprick when tested or withdrawal from noxious stimulus in the attended or aphasic patient. Only sensory loss attributed to stroke is scored as abnormal, and the examiner should test as many body area as needed, like leg, face, the trunk, arms, but not hands. To accurately check for hemisensory loss. A score of 2, severe or totally sensory loss, should only be given when a severe or total loss of sensation can be clearly demonstrated. Stubborous and aphasic patient will therefore probably score 1 or 0. The patient with the patient with brain stem stroke who has bilateral loss of sensation is scored 2. If the patient does not respond and is quadriplegic, score 2. Patient in a coma or item 1A3 are automatically given a 2 on this item. Item number 9 is best language. Okay, here we ask patient to perform the following. Okay, we ask patient to describe what's happening in this picture and to name all the objects in this card and to read these phrases. Okay, here we give a score 0 if no aphasia or normal. 1 for mild to moderate aphasia, indicated by some obvious loss of fluency or facility of comprehension without significant limitation on ideas expressed or form of expression. Okay, we give 2 score for severe aphasia, and we give 3-point efficient is mute. Okay, the patient in a coma, item 1A, we score a 3 will automatically score 3 on this item. Item 10, dysarthria. Okay. If the patient is thought to be normal, an adequate sample of speech must be obtained by asking patient to read or repeat these words: mama, tip top, 50-50 sounds, and so on. If the patient has severe aphasia, the clarity of articulation of spontaneous speech can be rated. Only if the patient is intubated or has other physical barriers to producing speech, the examiner should record the score as unstable and clearly write the explanation for this choice. And remember, do not tell the patient why she is being tested. We give 0 for normal, no dysarthria, 1 for mild to moderate dysarthria, 2 for severe dysarthria, or unstable if the patient is intubated or there is other physical barrier. Okay, item number 10, extinction and inattention. Sufficient information to identify neglect may be obtained during the prior testing. If the patient has a severe visual loss preventing visual double simultaneous stimulation and the cutaneous stimuli are normal, the score is normal. If the patient has aphasia but does appear to attend to both sides, the score is normal. The presence of visual spatial neglect or anosognosia may also be taken as evidence of abnormality. Since the abnormality is scored only if present, the item is never untestable. Here we give 0 if there is no abnormality, 1 for visual, tactile, auditory, spatial, or personal inattention or extinction to bilateral simultaneous stimulation in one of the sensory modality. We give a 2-point for profound hemi-attention or extension to more than one modality. Okay, this is the end. Sorry for this poor presentation. And thank you for your time. This is the end.
Thank you, Dr. Azhari. That was quite informative. I work with elderly people, and we have a lot of stroke patients. So this is very, very, very informative, and I'm sure that everyone here.
Thank you so much.
Thank you very much.
I appreciate it. Thank you so much. Anyone have a question? Anyone has a question?
Let me check the chat. Nobody have a question yet, but if anybody have a question, please feel free to send it in the chat. If not, send it to the group on the WhatsApp, and
Okay,
I'm sure the doctor will answer the questions.
Okay, thank you. Thank you so much. Okay,
All right, we're going to go to our next speaker. Is going to be Dr. Minnu. Will be speaking on how to make a scatter plot with trend line in Excel. So, doctor, if you are here, please.
Yes, I'm here. Hi.
All right. Hello.
Hi, I'm Minnu. I'm going to present about the how to make scatter plot with trend line in Excel. Okay. Am I audible?
Yes, I can hear you well.
Okay, I'll just share the screen.
They are asking in the group chat if you can send the presentations, both of your doctors, in the group chat later on. Thank you.
Okay.
Okay, can you see my screen?
Yes, I can.
Okay. So before going into the demo in Excel, I'll just brief about the scatter plot and how trend line is created. So let's go into the presentation. Okay, so scatter plot is a chart that shows relationship between two variables. It helps the viewers to immediately understand a relationship or trend. Okay, so this is an example for the scatter plot. So you can see on the x-axis the education, and on the y-axis you can see the females in their numbers. So you can see the data is plotted in the form of dots, and it is showing a positive trend, like directly related kind of. So that's about it. Now, what is trend lines? They are lines used to approximate the general shape of a scatter plot. So when we have a positive trend line, that means that the scatter plot has a positive correlation. And when we have a negative trend line, it tells about the scatter plot has a negative correlation. You may remember like the Pearson coefficient we have studied similarly. When we have a positive relation, we can create a positive trend line. Okay, and negative as such here. So this is a picture showing the relationship. So when we have the data more towards the trend line, I mean scattered more towards the trend line, that shows that the relationship is like very strongly positive. And if it is away from the trend line, it is like weakly positive. And if they are going in the negative direction, it is strongly negative, and the data is more concentrated over the trend line. And if it is scattered away from the trend line, we can say it is weakly negative. And this is like moderately negative. And when it is scattered all over, it's like no correlation. Okay. Next, how to interpret a scatter plot? So it is based on three criteria, like the strength, the trend, and the shape. Okay. So when we see the demo, it will be more clear for you, but I'll just brief it now. Strength means like strong to weak, like as we saw in the previous slide, like this is strong, strongly related, this is weakly related, like that. Okay. And trend is like positive or negative. So in this picture, you can see this is positively related, and this is like negatively related. Okay. And the shape is linear or non-linear. Non-linear will be mostly parabola kind of like this. And this is like the linear relationship. Okay. And we have one more thing which we already said about the Pearson coefficient, the R value. It is a statistic used to determine the strength of the relationship between two variables in a scatter plot. So we use this table to, 1 second, let me just. Okay, so you can see the table, right? So when we have the values between 0.9 to 1, we can interpret as, the R value, if the value comes around this, we can interpret it as very strongly related. The same way 0.7 to 0.9 means it's strong, 0.5 to 0.7 means moderate, and 0.3 to 0.5 means weak. And less than 0.3, I think. Can you see my screen? I'm not able to.
Yes, I can.
Yeah, below this, 1 second, I am not able to remove this. Okay, so below, between 0 to 0.3, it is like very weakly related kind of, okay? Next is the pros and cons of the scatter plot. So pros are like they reveal a pattern in a data, okay? And it is easy way of determining whether a cause and effect relationship between two variables exist. And also it helps to analyze the relationship between two variables. But the cons are, if the data cover too small of a range, the results of the analysis can be skewed. if it's very small. Okay, so we generally take at least like 30 values and then consider making the scatter plot. So it will be it won't be that skewed. Then patterns can appear or vanish based on how the data are stratified. If there is a pattern, it does not always indicate that there is a relationship. There can be a positive and negative, pattern that doesn't show that really it is, related kind of. But we can say it is, there is a, what we can say, like relationship is the, yeah. Let's move to the demo. 1 second. So this is the Excel. So how we can do a scatter plot with the Excel, okay? So I have created a data here. I just took like 10 data, but generally it is good to take more data, at least like 30 kind of data. Values can be taken. For easiness, I just took like 10 values. So here I'm considering x-axis, which is an independent variable. That is, for example, the time spent with the doctor in minutes, okay? And y is like the dependent variable, that is a patient satisfaction score. For example, like this much of time spent with the doctor and the patient is satisfied or not. So 0 is like not satisfied and like 10 is like very satisfied. In between we score it, okay? So how can we create this? First, we will select the data, okay? And then you can insert, you can see scatter here, the function scatter here, and take the scatter with only markers, okay? So you can see the scatter plot is created, okay? Now we can do is, we can name this, okay? Plot. This is kind of relationship between time spent with the doctor and the patient satisfaction, right? So time spent with doctor versus patient satisfaction. Okay. Then now we can do like axis. Each axis can be titled, like x-axis as well as y-axis. So how can we do is take the layout in the taskbar, and then you can see the axis titles, okay? And in which you can take the horizontal axis title, that is the x-axis, and title below axis, okay? So we are x-axis of time spent with doctor, okay? And in minutes, okay? Same way, in the layout, the axis title, the vertical axis, rotator title, so that we can put the title like this. In which the patient satisfaction score, okay? That will be between 0 to 10. Okay, so that's it. And I'm just pulling this slide a bit more so that it will be, yeah. And next comes, we see like the scatter plot data plotted. We have to remove these grid lines, right? So how can we do that? In the layout itself, you can see the grid lines, And here we have the horizontal grid lines. So we are removing that. So you can see clear scatter plot is ready. Now, how can we create the trend lines? Okay. So how is it? So what we have to do is, you can see in the layout itself, the trend line, and we create the linear trend line. Okay. So this is how the linear trend line is created. Okay. And then now we can see, we said about the Pearson coefficient, right? How can we calculate Pearson coefficient using Excel? Okay. So what we do is, before going to that, I have something to be added here. That is, we can even change the color of the plotted, data. So we just right-click on the data and format the data series. So marker fill, solid fill, and I'm changing the color to black. Okay, like that you can do. Okay, so that's ready. And now, so this is a patient satisfaction score, right? We can even change the units given here, right? 0, 2, 4, 6, 8, and like that. So I'm just changing the units. I'll show that. So click on the number, right click, and you can format the axis. Okay. So what is this is, I'll explain. So here, so this is a y-axis, and this is an independent variable, and we are scoring it between 0 to 10. So each unit, major unit, this one I'm changing to fixed ones. And you can see the major and the minor units, right? And in that, the major unit, I'm changing it to 10. Because 10 we are doing. Sorry, 1 second. Okay. Here, major unit means each 1, 2, like that. Okay. Second, and the maximum value will be 10 here. Sorry, change it to 10 here, and minimum value will be 0. You can see we are scoring the patient satisfaction score between 0 to 10. The maximum value is 10, minimum value is 0, and each unit means in between 0. For example, if we keep it like, okay, major unit is 5 and minor unit is 0. So the place in between, this will be bigger, smaller, like that. Okay. So I'm keeping it as 1 unit. So y-axis is done the same way. On the x-axis, I'm formatting. Here, I'm changing to fixed. The maximum value here is 20. Okay. And the minimum value is like 0 minutes. This is 20 minutes and 0 minutes. And the major unit is like the same way, 2 and 0. Okay. Sorry, I'm changing to 1 itself here. Okay. Maximum value 20. 1 second. Yeah. Maximum value is 20. Minimum value is 0. The unit in between is like 0, 1, 1, 1 units. Okay. Okay. So I'm just keeping it as square because generally the scatter plots are like in square. Now we can move on to the Pearson coefficient. How can we find the Pearson coefficient? Is that clear for everyone like till now? Hope it's clear. I'm just moving on to, in case if you have any doubts, just stop me. I'll make it clear for you. Okay, so how can we find the Pearson coefficient? So for that, what we do is, in home, you'll go to the functions, 1 second, home, and here you can see the, 1 second. Let me just select it. Okay, I just selected the data. Now I'm going to find, I'm finding the functions in which I'm typing the Pearson. Okay, go. So you can see the Pearson selected. So they are asking array 1 and array 2. Okay. 1 second. One second, okay. I just select. Or 1 second, I think I have deleted one data. Seven. Oh, yeah, okay. So function. One second, okay. I click functions, Pearson. Okay. So here, okay. So array 1 means the X variables. Okay. And array 2 means the Y variables. Okay. And we selected each one. And now we are clicking OK. So you can see the R value as 0.99. Okay. So this is the value which we got at Pearson. Once again, I'll repeat. You have to go to the home and see the functions and drop it down, select for more functions and click Pearson and select the each array. Array 1 is X, which is independent variable, and Y is dependent variable. In array 2, just add Y and then go OK, you'll get the Pearson value. So going back to my presentation in which we saw the Pearson coefficient values, right? So here you can see if the values are coming between 0.9 to 1, it is very strong. So we got the R value as 0.99. So it is like very strongly related. Okay. And also here it is a positive trend we got. Hope it's clear. I'm just going back to my presentation so that we'll get we can go through a summary of like whole scattered plot. So a scatter plot uses coordinates or dots, displays what happens to one variable when another variable is changed. The independent variable is plotted on the x-axis. Okay. For in our example, the independent variable was independent variable is plotted on the x-axis. And the dependent variable is plotted on the y-axis. The data type is either continuous or attribute data. The minimum data, I said, like at least 30 observations of player data should be there. And the interpretation is based on 3 things: the trend, the shape, and the strength. Okay, positive and negative trend, the shape, and like the strength is like how strongly or how weakly it is related. Shape, usually linear, and it can be parabola type also. The scattered plot does not prove causation between the 2 variables. It shows a relationship, the correlation or the association. The scatter plot should be square in shape, not rectangular. And the Pearson correlation coefficient, as known as Pearson's R, is a statistic used to determine the strength of the relationship between 2 variables in a scatter plot. hope it's clear. That's the end of my presentation. Do you guys have any doubts? Please just ask.
Thank you very much, Dr. Minnu.
Thank you so much for listening to me too. And also thank you so much for my group team members, like giving me an opportunity to do this. And thank you, Dr. Nadir.
Thank you very much. It was a very good presentation. And I know it's not easy whenever the topic's about Excel and stuff like that. It's not easy. So thank you very much. It was very clear.
Yeah, thank you so much. Like, hope it helps you because I was also learning with this because I haven't done a scatter plot earlier, but I was learning along with every one of you.
Yeah. All right. So if anybody have any questions, please feel free to ask them in the chat or in the group in WhatsApp. And if you don't mind, Dr. Minnu, to send the slides as well. They will be available in the app, but if you can also send it to the WhatsApp group, that would be great.
Yeah, sure, I will send it.
Our last speaker is Dr. Hasan Al-Idrisi. Hasan Al-Idrisi, he will be speaking on critical appraisal. Dr. Hasan, if you are here, feel free to join.
Hello. Can you hear me?
Yes, we can hear you. How are you?
All right. So I'm going to share my slides now. All right. All right. So hello, my name is Hasan Al-Idrisi. I'm going to talk about critical appraisals today. So what is critical appraisal? It is the process of carefully and systematically examine research to judge the trustworthiness, value, and relevance in a particular context. It is the process of evaluating and analyzing various types of information, such as research studies, articles, reports, or any other source of information in a methodical and structural manner. This process is commonly used in fields such as healthcare, scientific research, academia, and evidence-based decision-making. Why it's important? The goal of the critical appraisal is the assess of the quality, validity, reliability, relevance, and credibility of the information presented in these sources. It allows us to reduce information overload by eliminating irrelevant or weak studies, identify the most relevant papers, distinguish evidence from opinion, assumption, misreporting, and belief, assess the validity of the study, assess the usefulness and critical applicability of the study, and recognize any potential for bias. All right, here are the 5 steps of evidence-based practice that just provide a framework for approaching a question. It's also known as the 5A. First one is ask. Basically asking a well-built question. Asking answerable question means formulating questions into a format whereby you can integrate the medical literature and hopefully find an answer. To do this, we usually utilize PICO tool, which is population, intervention, comparison, and outcome. Step number 2 is acquire evidence. In another word, searching for evidence, tracking down the best evidence with which we can answer the question. Step 3 is appraise the evidence, and that critically appraising the evidence for its validity, how close it is to truth, its impact, the size of the effect, and the applicability. Is it useful or not? Step number 4, apply the evidence along with your clinical judgment and patient values. Number 5, assess the results, effectiveness, and efficacy. And the circuit goes on. How to do it? Critical appraisal typically involves several steps, which may vary depending on the specific field and the type of information being assessed. So some of the steps are identifying the research question or objective. That means understanding the purpose and scope of the study or information source. Another step is assessing study design, evaluating the study design for if it's appropriate in addressing the research question. Different types of research designs have different strengths and different limitations. Right, here are some checklists that is usually used to critically appraise the different study designs. Then another step is evaluating methodology, analyzing the methods used in the studies, including data collection, sampling, interventions, measurement, and statistical analysis. This step ensures that the methods are rigorous and appropriate for the research question, and appraising the results to determine if they are accurately presented, statistically significant, and relevant to the research question. Considering bias and confounding, identifying potential sources of bias and confounding variables that could affect the validity of the results, examining the applicability of the study or the paper, assessing the relevance of the study finding to real-world situation, patient population, and context. Evaluating strengths and limitations of the study, recognize the strengths and weaknesses of the study, including limitation in design, methods, and data interpretation. Considering implication, reflecting on implication of the study findings and how they might inform practice, policy, or future research, and forming a conclusion, which is drawing an overall assessment of the study quality and reliability, and determining its credibility and applicability. So critical appraisal is crucial for making informed decisions, especially in the fields where evidence-based practice are essential. It helps professionals avoid relying on flawed or biased information and contributes to the advancement of knowledge by promoting robust research and rigorous analysis. Here are the references. Thank you very much for letting me talk to you today.
Thank you very much, Dr. Hasan. If anybody has any questions, again, feel free to send them in the chat or in the WhatsApp group. And if you can share your presentation, Dr. Hasan, to the group chat on WhatsApp, that would be awesome. So we finished our presentations. We have around 10 to 15 minutes to discuss the upcoming projects. If anybody has any updates for Dr. Nadir about their projects or any questions about starting projects, feel free to join. Before I hand the mic to Dr. Nadir, I just want to say thank you for the yellow team. You stepped up and you were great. All the presentations were very good. Thank you very, very, very much. And I'm really happy to work with you. Thank you. Dr. Nadir?
Hello. Thank you so much, the shadow team. Thank you, all the presenters. These are great presentations. Thank you. So if there is no questions, we can move on to the last part. Any updates?
Hello, Dr. Nadir. Hello, everyone.
Hello, go ahead, Fatma.
I'm Fatma Ahmed from the Orange team. We're doing a research on the public access of automated external defibrillator and out-of-patient cardiac arrest. We're on the data extraction step, and the only thing that's left for us is the quality control. We'll finish by the 10th of September, inshallah.
Good, inshallah. Excellent.
Thank you.
Perfect. Thanks for the update. Anyone else? Any new ideas? Any working on the apps, mobile app?
Hello, Dr. Nadir.
Hello, Dr. Ahmed, go ahead.
So yeah, we almost done. We just have to add the authors, but we're done from all the features, like 100% of the app.
Sounds good. Excellent. I think, okay, yeah, good. So what's the plan for the next step?
So our next step is to add the authors, and then we will proceed to the step of uploading the application to the Play Store. Nothing left. We just have to work on uploading the app.
So my suggestion is, if you have the team members ready, or if you want to add additional team members to work on the advertisement. So when you launch the app in the store, I think if you have enough fellows or people in your team working to get the work spread or get people attention, so that they can from day one they can visit the website and download and test the app and maybe give feedback. That would be great. So if your team has 20, if every one of you has 5 or 10 people, this would be maybe 100 people or maybe 200 from day one. So you don't have to struggle like the first time, the first app that we did together, right?
Yes, right. So this is a great suggestion, and I think I'm hopeful for this one. Actually, more the INR app, because I think hypertension, yeah, it's very common, and I think this is a useful tool to all patients, to all hypertensive patients.
And if it is some of the fellows who did not participate in the development or the actual app development, maybe they can work on the other aspects of the app. Maybe they can seek some comments, some inputs or feedback from users, so they can encourage other users to tell you what's good, what could be enhanced or improved in the next version, and so on. So they will be able to participate in that way, and they can put it in their video of the app application, and they can talk about the app themselves when they work or use it.
Yeah, that's great. And we're also planning to make more application in the future, because we're really enjoying this, and I'm planning to involve almost all fellows in different applications.
Perfect. Excellent. That's a great idea.
Yeah, thank you so much.
Thank you. Thanks for that. Anyone else?
You're welcome.
This is Iman again.
Yes,
I'm not sure if they already updated you about it, but the COVID-19 and pancreatic disease in geriatric population group research led by Dr. Mafaz. We got accepted for a poster presentation in the upcoming gastroenterology, American Gastroenterology conference in Vancouver, Canada, and I'll be presenting in October, inshallah.
Oh, perfect. Congratulations.
Thank you.
That's good. So if you can just send me an email and update me.
Yes, I will.
You-
I'm working
you have-
on creating the poster. I'm currently working on it, but once it's finished, I will definitely send it and hopefully be able to present it here so I can get the feedback.
Oh, perfect. That would be great. When is the conference?
It's in October 20th, in October starting from the 21st to the 25th, but the day of my presentation is on the 23rd.
Excellent. Congratulations.
Thank
Good
you.
job. Good job. Thanks for sharing. Anyone else? How's the
Assalamu alaikum,
Go ahead.
Dr. Nagi.
Go ahead.
All right, so I see that Dr. Ahmed should already update you on the app. The only thing that we're not going to be able to link any app or any extension for the graph and for the blood pressure readings and grafts. So that's the only thing. Dr. Sepa, she worked very hard on that, but unfortunately she couldn't go to any result. You know, like she didn't find any way that we can add or link anything.
Right.
So I don't know what the next step regarding that, because apart from that, our blood pressure app is done. So
maybe who is working on the development, actual, like Cordula, who is working on the coding on the You are
Who-
Amal or who?
Amal, she's the one who work in the codular.
Okay, maybe if you have a minute or two, Amal, maybe you can work on it after this meeting.
Yes, sure, Dr. Nader, of
Let me
course.
see if you can figure out a way.
Yes, of
And
course.
also, Amal, if you can give him the access, same as Dr. Amar, because I think he's not going to add anything. So if we can just transfer the access to Dr. Nader, that would be perfect.
Yes, of course. I can export the entire project and send it to you via Google Drive.
As an AIA, right? Right.
Yes, yes.
Okay. Good. Excellent. Good job.
Okay.
That's good. Anything
Yeah.
else? Nafisa?
No, that's it. We done, and I think we have. I received the fellow that you sent them for the testing. I think until now, because we have some fellow that they didn't do the task, so that's they're gonna be their task as well. And I will let you know about. We have 2 leader right now for the Spanish as well as Arabic.
Excellent. How is the Spanish going and how is the Arabic version going?
The Arabic version, I didn't hear yet from Dr. Dora. I'm gonna contact her again. But regarding the Spanish, she's ready. As soon as we just finish the app, she's gonna give us like she said, she's gonna work on it in 1 or 2 days. That will be ready. It just will have to upload everything. Yeah.
That's perfect. Excellent. That would be great.
All right.
Thank you so much for that. Thanks.
You're welcome. You're welcome. And regarding, I just want to ask you regarding the thing that I asked you last week about the AMR. You give me a suggestion that we can actually take a paid version of AMR and we share it between provider. If you could just send me this information in the email, because I would like to go and do some research on it and do a proposal for that.
Okay, so remind me again. So I told you there are some paid versions for the EMR, like
Yes.
a demo, or you want to get, because I can share with you now, I think, let me see. So several years ago, when we started the I'm trying to reach the website. So several years ago, I started working on the AMR individually. So I connected with an email that was offered free, and then later was by subscription. It's called Practice Fusion. So
I worked on Practice Fusion before. I found it very simple and amazing. I love it, to be honest.
Yeah. So they have what's right now. I think they have subscription based. So you sign up. The pricing for that, I think, is monthly 140, 150.
Perfect.
You can start a free trial. I'm not sure for how long, maybe a month or so. And then you can record what you are doing so that you can have a version where you want to teach up about it, if you want to have it and record it, or in actual time you want to do that, let us know, and you can just have about 10 minutes, 15 minutes, you can demonstrate this.
Okay, that's amazing. Thank you so much. I didn't know that the Practice Fusion is so I think the amount is convenient, and I work on it, as I told you, that it's amazing. It's very simple, to the point, and I like it. It's less complicated than eClinic or the other EMR.
Yeah, the other, either they're expensive or they're very technical that you have to go through training and to figure out where is the note and how to whatever.
Exactly.
Yeah, so I use different ones. My preference is a simple one. This one was very simple. Now I go to nursing homes and they have their own app. It's Point Click and Care, also very simple. So we use that in long-term care facilities. So
Thank you. Thank you so much.
excellent. Thanks. Anyone else?
Iman again, sorry.
Yeah, no problem. Go ahead.
I also wanted to update about our research led by Dr. Asma Mustafa on the physical, mental, and social difficulties of older adults with disabilities during COVID pandemic. Was also accepted for a poster presentation at the PCRG on coming October. It will be presented by Dr. Nawad.
Oh, perfect. Excellent. Thanks for that. Congratulations. This is great also.
Thank you.
So we are asking for some funding for the fellowship. So if we secure some, I'll update you, and we'll be able to cover some of the cost for these conferences, inshallah. Otherwise, we'll have to figure things out. I know you are working hard, and congratulations on your hard work and great job. Anyone else? I know some of you might be in the process. Some already submitted. We are waiting for some of the submissions in the manuscript or posters. And also other conferences we can try to approach and see if we can submit more papers or manuscripts on abstract. Any other questions? Any other ideas? Concerns regarding the fellowship or your application? I wish you all the best with the application. Is it September 15th is the date that you launched your application, or you already started?
Hi, Dr. Nader. I'm Lana. I just have a question regarding the ERAS application. Actually, we got confused about this, like the telegeriatric fellowship. some of people said like we have to put this under education, and some they said we have just to put it under experience. So we just need your opinion about this. Thank you.
Okay. Why don't you put it in both places? There is no accurate right or wrong way of putting it. It's an experience for you guys, and it's a research experience. It is hands-on. You will be, or you already are involved in some either presentation with the team or work in a project with the team. Some of you might be a team leader or you work in teams as a team player. So all this will count as an experience. Some of you were successful of submitting the work in the manuscript or abstract, and some got accepted and some presented or it's going to be presented. So all this will be a work experience or research experience as far as the part where you want to put it in your application. The other part is the learning or educational part. So we are learning. So the first part of this meeting was about preoperative. So it's kind of a lecture based or information sharing based. But in addition, we also touch base on some aspects of the research. So how to draw graphs, what's the importance of the graph, how to summarize your work in research. Or, and the last topic was about analyzing. So you want to read an article. How can you appraise that article? How can you analyze, make sure is it helpful, is it waste of your time, what to do with these articles. So all these are considered part of educational. It's like the word fellowship is you want to learn more about this aspect. And so for you, it's an additional year for education. And you will learn more about geriatric medicine, long-term medicine, and also some educational parts about the research aspect. So there is no wrongdoing of putting it in either or two places in your application.
Okay, thank you so much, Dr. Nader.
You're welcome. And during the interview, they may ask you about the fellowship. So whatever aspects you got involved in, you can elaborate on that. So let's say you were involved in presentation, so you can talk about the meet every week, and some people will present as a team or an individual. The topics may vary, we touch on this, so you can express yourself in that area. Otherwise, if you are involved in a project, you can talk about your project. And sometimes they ask you specific questions. So you can say, and my part of this project was to do this, and we work as a team and publish in this whatever. Okay. Wish you good luck. Nidal, go ahead.
Hello, Dr. Nader. I'm just asking also regarding IRAS application. In the section of publications, I have done I have published some researches with an international group. Like the authors, you can say the authors will be 1 million of people. So in the part of the authors, should I can't involve all these people. Should I just write my name and ignore the others, or what should I do? Or should I leave it just empty?
So it depends on if you work with 2 or 3 people, you can add them in your publication. So you wrote a paper, you can list yourself and 2 or 3 or how many in that paper as authors. If you work with 20 people, so you can put your name and an additional name, maybe the leader of that project, and then ETAL. ETAL. That means you and the other member and along with the team members, so they don't have to know how many members in that team. So you don't have to list the whole 20 people, if that makes sense. So if you have a limited space, you can use 1 or couple of names and then followed by E-T, the space A-L, that means others.
Yeah, okay, got it. Thank you so much, Dr. Nader.
Sure. Wishing you all the best. Anyone else? So if no more questions and comments, I would like to close this meeting. I'd like to thank you, Dr. Bai, and your team, and all the presenters from today. Thank you so much for great presentation, great work, and thank you all who attended today's meeting and also will watch the recording later. I wish you all the best. Good luck. Assalamu alaikum. Good night and have a wonderful day. Good night.
Thank you, Dr. Nader, very much. Thank you.
Yeah.
Thank you, Dr. Nader.
Thank you,
Dr. Nader. Thank you so much.
Thank you.
Assalamu alaikum.
Assalamu alaikum.
Thank you, Dr. Nader.
Thank you so much.
Thank you.
Thank you. Assalamu alaikum.
Assalamu alaikum.
Hello, Dr. Nader.
Hello, Dr. Aman.
Yes, I'm here.
Yeah, if you can share your screen, I can work on.
Okay.
Maybe
Okay, sure. Just a minute.
Sure.
Is it clear, my screen?
Yeah. So let's
Okay.
see.
So let me go to the designer interface.
Mhm.
So I think we wanted to add the chart in the summary page, like in chart review. Here, but Codular itself doesn't contain a feature called charts, unlike Light. And that's why we have to import an extension. Here I imported the extension. So if I put the extension here, it will show the characteristics of the extension itself. But it was, for me, it was actually complicated. I couldn't do anything with that. I watched a tutorial on YouTube and I followed the exact same steps, but it didn't work at the end. When I did the test, it didn't work. So let me show you. So I should like use these blocks, but it didn't work. Even it's complicated because it should be something like progressing. Whenever a patient adds a new reading, like systolic, diastolic, or a pulse rate, it should, the graph should like draw lines and things like that, or presented in a histogram, but all didn't work.
So if you want to, let's say, go to the last part, create line graph. Let's see, yeah, just, and so the data point will be X axis point and X Y axis point, the last.
Yes.
These. So these are the ones that you're gonna get them from the what let's say from the user, right?
Yes, I think the readings themselves, like for example, the x-axis should be the systolic reading, and y should be, for example, the x should be the date, and y should be the readings.
Yeah. So.
So I think it should be stick to something, because if it's like this, it won't work.
Yeah.
So
no,
just
when you start the page where you initialize this page, do it, and it's gonna be at the end there.
Yes.
At the lower part. Yeah.
Yeah, this is too long. That's why I have to scroll down. So I think x-axis, the dates, maybe we can do. It doesn't stick. It means that it's the wrong order.
No, tiny date. Okay. So what we want to do is
This is the database, sorry.
mhm.
I should stick the text itself. Okay.
Date month there.
This is a database.
Database. Okay.
Yes.
What is it for that?
The problem is that there are too many dates, like dates for each day of the week. So I have to join them together. Maybe. It doesn't work.
Yeah. So
Maybe I can join via a list.
yeah.
Yeah. Yes, and then the y-axis should be the systolic or diastolic.
Let's do one. Let's do systolic, for example. I just want to know if we can get the graph working.
Okay.
Yeah, no, you can add it to the up to the point there. Okay.
So I should make one reading just to test the graph?
Yeah, yeah.
Okay, so I think I should remove the list and just add one reading.
No. Add the list,
Okay.
instead of this, you can just.
Okay,
What I
sure.
mean, not the systolic, diastolic, and whatever. That's systolic. I think it's just you can add text for the color. You can add number for the width, the height of the graph.
So the color, we can add any color, like
Yeah.
just to
any color
complete
from
the order.
color, yeah.
I don't know why it's not sticking.
Oh, okay. Maybe it needs a text to go to text and add like here, and you can write something like that.
No.
Line.
So let's choose the arrangement, maybe. I think arrangement, we should put it here first on the design and then add it on the coding.
Sure, sure.
I don't know what to choose, but I'm going to choose the vertical one.
Okay.
Just I want to memorize the name of it.
The name is on the vertical and dash arrangement tool. It's on, yeah, this is the down. You comment.
Too many components. That's why too confusing to search for something. I think those should be like something mathematics, height and width.
This is numbers. So if you go up all the way, it's supposed to be.
Yeah, but I'm not sure what to put.
100. Math, yeah. On top of the 0, yeah. Maybe 100 by 100. I don't know. It's gonna be small, but we can increase it to 200, 300.
Yeah.
And then
the duration itself is also a number, I think.
Yeah, it's supposed to be like 2 seconds. Let's do it 100.
2 seconds. Maybe I think 2 seconds is written like 2000s.
Yeah. Line width maybe 2. Value. I'm not sure.
Maybe
yeah, 10. And then the width maybe 2. The line, the width of the line. And then the colors, that is the color. If you add it.
I'm not sure if it's gonna work here or not, but I don't think so.
How about text? Can you add text here?
No, it doesn't accept the text.
Line colors.
Colors, maybe the S is for something plural. Like maybe we should add a list of colors, not one color. And that's why it doesn't accept.
Yeah, maybe add colors list, yeah. And then you can add the colors maybe red and yeah, and green or whatever.
I think this is a text, but I don't know what to write.
Let's try sampling.
Sorry?
systolic.
Okay.
And then the description systolic.
Also systolic.
Yeah, it's just to see if it's gonna work, and then you can modify all these.
Okay. So I think we filled all the gaps.
Yeah.
And now we should test.
Call simple chart one. Oh, we need to call simple chart one. What's that called? Simple chart one.
I think this is for when screen initialize, call simple chart one. So
okay,
we should,
yeah.
I should put the phone on the test mode and see if it's gonna work.
Okay, let's try it.
Okay. So I'm going to scan the barcode, and it's going to take about 3 minutes or 2 to 3 minutes. But, sorry, first of all, I should connect to any desk to be able to show you my screen.
No, just I want you to know if it's working or not. You don't have to share it if it's
Okay. Okay, sure. So here my phone is connected. On my phone screen, it doesn't show anything. And here it shows the same error message that appears on my screen.
Yeah, it took longer for the process the information. So that's fine. So for the first version, maybe we can think about just doing it without the graph. How about that?
Okay, so I think, yeah, I think this is a wise decision.
And then version 2, we can work on getting that working. I think we need to tweak something here. It might be just simple, but we don't have to waste our time right now on that. So we can figure it later. We can figure it out.
Yes, that sounds great. Also, I have read on the cardiology community, people found that there are some problems with the extension itself. Like the extensions are created by programmers, and sometimes they make mistakes. They are not created by the platform itself.
Yeah.
So yeah, sometimes they don't work.
So yeah. There is another way of doing it, but we need to have all the information. And the same way you just collected them here in the. So for you, I think I shared the email with another server, but I'm gonna see if I have that email. Nafisa, are you there, Nafisa?
Yes, doctor.
Okay, so Nafisa, I sent you an email with highlighted. It has the image.
Highlighted what? Sorry.
Okay, let me see what email did I send.
I shared the last emails with Dr. Amal as well. Just let me go back and see. But I'll share it now. Okay.
So I'm gonna share the screen with you, Amal.
Okay, of course.
So this email, she can send it to you. I can share it with you. But basically, this is a location of an image, and that image can be changed. The variables on the data here, you can insert. Let's say this systolic pressure, and the first reading was 120, second reading was 140, and so on. We can add them. So you need to keep this text in blue as until 5B. This is the first section of the image website, and then you add the number of the reading systolic, and then you add percentage 2C, percentage 20 as a text, and then you add the other readings, if that makes sense. And then the rest will be also a text until here. Oh, no, until the dates, or if you want to add some dates or the points of the date. You don't have to put the point of the date, but if you leave it like that, hopefully it's gonna be working for you. So what I would do, I can copy this, for example. So if you copy that text, it's gonna have the whole website for the image itself. But here, somewhere 120 and 140, we're gonna change them. So if I copy that, the same, I copy this to another website. I press the first. You see here the graph, 120 and then 140. If I change that, 120 and 140 to maybe 130 and 160. Like from here, I add the same website, it's gonna go 130 to 160. Does that make sense for you guys? So
Yeah,
what
it makes sense. But where should I like copy paste the entire text in the Coagular?
So in Coagular, can you add an image?
Yes, I can add an image.
And can you add a link to our website, like an image from our website?
Yes, I can do that. Via a URL?
Yes, the URL
Yes.
will be this text. So this text will be dynamic, and it's gonna have the blue part is static. This is where you're gonna copy and paste. And then the 120 and 140 will be the reading from the Monday, Tuesday, or whatever. It's gonna be plugged in these numbers, the 120, 140, and so on. So each time the person will add a number, it's gonna be in that place.
So I will try that. I'm not sure if it's gonna work, but I'm going to try that. I think I will face a problem with databases because everything should be saved.
Let's do one thing. I'm gonna send you that email again. I sent you the link again. Try to insert an image with the link, the URL address. Just copy paste this one and see if that can show up. If it can, then play with the number 120 and 140, see if it's gonna change, and so forth. If we can figure this out, then we can, the text itself, we can break it into pieces. So the first piece until before 120, and then 120 will be the user input from Monday, for example, and then there is a connection, and then the space after that will be the 140, which will be the space for the user to enter Tuesday reading, for example, and so forth. So
Okay,
let's
sure.
do it one step. Let's see if the graph will be working, and then we can take it. Okay.
Okay.
Thank you.
You're welcome,
Anything
Dr.
else?
Nader. Thank you so much.
You're welcome. Any other questions, guys? If not, then we'll see you next week, inshallah. Assalamu alaikum. Thank you.
Alaikum salam.
Alaikum